everybody. Thank you so much for coming. I really appreciate Corey, April, and Siobhan coming to watch my presentation for school. I really appreciate it. Alrighty, so with the school, I have to do a evidence-based practice presentation, and I have chosen about fall prevention guidelines. Okay, so the title of my project was Consistently Implementing Effective Fall Prevention Guidelines, and what those beepers, alarms, and cell phones are really for. Okay, the purpose of this project was to reinforce the need for fall risk guidelines by discussing 3 important interventions that are included at our facility but have not been used much lately. We've kind of been forgetting to log in, not carrying around our cell phones. So those 3 interventions I am focusing on for this project is hourly rounding, technological devices, and patient education, especially our LodgeNet software. Okay, here's some following facts. 800,000 patients are hospitalized each year due to falls. Hospital costs for fall injuries are approximately $20.6 billion per year. And one fall doubles a patient's chance for another fall. And those are facts from the CDC, or Center for Disease Control and Prevention. Patient falls are a primary cause of injury at hospitals. And falls occur when patients have a need to use the restroom but have to wait for assistance or have altered mental status and don't use the call system like they should. Okay, the problem is inconsistent use of fall prevention guidelines such as sporadic or non-use of bed alarms, staff trackers, beepers, and cell phones. They've all created an increase in falls. Patient education videos are also not being consistently assigned and viewed by our patients. This is sometimes due to alarm fatigue and high patient to nurse ratios. We get really busy, and we also get tired of hearing the beeps over and over and over again. The alarm's going off, so we kind of just don't put them back on. The fall prevention culture of our facility must be enhanced to allow staff members to feel responsible and vested in the program. Okay, when we think about our root cause and the fishbone diagram, who is, each factor that's affected, people, they forget to log in, or they're very busy, or they just don't care. Our methods, we got cell phones, they're time consuming to use at times. I know recently I've heard a lot of people saying that it's, time consuming to text each other, but the more we use them, the better we get at them. The machines, we have to be sure that our phones are charged or that we're logged in. Batteries are, working. Materials, we need the tracker, the cell phone, the bed alarms, video education. There's so many things to carry. Our pockets get really full. And then measurements, we need reports showing who is not logging in. And then our environment, there's so many alarms sounding. So these are all root causes for why we're not following our facilities guidelines. Adverse patient outcomes and effects to nursing care. Falls decrease patient outcomes by adding injuries to already compromised patients, as well as increasing time spent in the hospital, which may place further financial burden on our patients. Falls decrease nursing effectiveness by increasing time spent with that individual patient. It's time consuming to get a lift to help them off the floor. Several different nurses may have to come in and help, and we're all with that one patient. So we're taking time away from our other patients, and then we also have to do reporting. All our incident reporting is very time consuming as well. Okay, well, the purpose of change. Unless fall prevention guidelines are consistently used and reinforced, fall rates are going to continue to increase in our acute care setting. All right, so the first one that we mentioned was hourly rounding. It allows us to visually see our patients and know they are alive and well. It also allows our patients to verbalize any requests that they may have. It allows us to see if there are any environmental issues that need to be fixed, like wet floors or, a bunch of junk on the floor where they could trip. or anybody could trip. And then hourly rounding decreases falls by providing opportunities for patients to request assistance to ambulate or verbalize needs without having to get up and ambulate. All right, our second intervention is technological devices. Bed alarms warn us when unsteady patients are trying to ambulate. Tracking devices locate staff when there is a need for them. If we're not logged in and somebody gets hurt or one of our patients is not doing good, then we unfortunately don't know where somebody is. So it's important to have that tracking device on and be logged in. Cell phones allow for communication to and from staff members, and patients can notify us too when there's a problem. We can give them our extension to our cell phones and they can call us directly, and that even shortens the time for response. And then our last intervention is our patient education. Education about use of the call system reinforces use. It reminding with each contact reinforces education. Just about falls, don't get up without calling me. We're constantly educating. That's what nurses are supposed to be doing. The use of the LodgeNet software for cognitively sound patients gives another layer of education regarding the need for following fall prevention guidelines. Our LodgeNet software is greatly underused. We have fall prevention information, stroke information, cardiac information, and it is not being used like it could be. Okay, so positive outcomes from implementation will affect change by improving response time to patients, which will decrease falls. Communication between staff members will improve and be easier. Like I said, the more we use the devices, the better we'll get at them, and they'll be just like our regular cell phones. And then cognitively sound patients will gain a better understanding of risks for falls, and patients with impaired mental status will be checked on with consistent regularity. So recommendations that I have for us, all staff members must carry their technological devices and be logged in each shift. There's no ifs, ands, or buts about it. A designated person could provide each staff member with activated devices or reports of activated devices, and response times will be generated and reviewed by management. And repercussions for staff members not using the recommended technological devices have to be done. Unfortunately, if we don't have repercussions, we don't learn from our mistakes sometimes. Okay, and then all staff members will wear their tracking devices and perform hourly rounding as recommended by our facility. And an in-service refresher class will be held to reinforce the use of the hourly wall monitoring system. There's just a lot of buttons on there, but if we use it and we get a little in-service refresher, it'll help us to remember how to use that system. Another recommendation is educational videos regarding the topic of fall prevention will be viewed by the end of the first day for all qualifying inpatients. And an in-service class for the LodgeNet software will be given to review how to assign those videos to all of our nurses. All new nurses will be educated on how to use this software as part of their orientation. I know that was not something that they discussed with me during orientation. It was kind of a, oh, we have that, okay. All right, so in conclusion, through the use of several different interventions and guidelines, we can see that evidence shows the risk for falls will be improved, but must be used regularly in order to improve patient outcomes and decrease falls. All right, thank you so much.